Marvin Natowicz. I'm a medical geneticist at the Cleveland Clinic, and we're fortunate today to be able to talk with Professor Judy VandeWater from the University of California at Davis in the Department of Internal Medicine. And Professor VandeWater is a distinguished researcher in the field of immunology. Today, the film will be addressing issues of immune function and dysfunction in children and adults with autism. The specific learning objectives for today's session include discussion of what types of clinical immunological conditions affect persons with autism more than age-matched controls. Second, what types of clinical laboratory immunological test differences there are in persons with autism relative to age-matched controls. And third and finally, what are the major clinical and research frontiers in the field? So thank you for being with us, Professor VandeWater. To begin with, can you discuss for the viewers the types of studies that have been done to evaluate immune function and immune dysfunction in children and in adults along the autism spectrum?
That's a pretty broad question. A number of studies beginning actually back in 1977, people were beginning to think about autism a little bit differently and trying to understand some of the medical, or sort of the more medical side of autism versus just the behavior. And in those studies, they were looking at the different cellular components and how they functioned before we had a lot of the tools that we have now to do that. And so we've, in the last, probably beginning in 2000, we've begun looking more, I think, at a different level now at immune function in individuals with autism. And some of the things that have come out of that are differences in cell populations, right? This is sort of more at the basic level. Differences in immunoglobulin levels in children with autism, increased allergy. I think there's some discussion of how strong those findings are, but one thing that we do know is that children who have exacerbated allergies have worse behavior because, like those of us who are miserable when we have allergies, it impacts them even more, according to the clinicians at the Mind Institute. In autoimmunity, do they have increased incidence of autoimmune disease disorders, both in the children and the adults? And what are the long-term ramifications of those? We look at it sort of as we would any health sort of outcome, except that we know that what we find might be a little bit different in this population than we see in the general population.
And is there data that is agreed upon or conclusions that are agreed upon at this point regarding prevalence of any type of immune dysfunction, either in terms of clinical manifestations such as allergies or autoimmune disorders in persons with autism, or any clinical laboratory findings that are more common in persons with autism?
I think one of the clinical findings has been increased infection early on, increased ear infections, sort of more a propensity toward multiple, and bacterial especially, infections early on.
In persons with autism?
In persons with autism. That children with autism, if I had to describe it, it's as if their immune system is maturing at a slower rate. And some of the work that we've looked at, that they eventually catch up, but they have this heavy load of early sort of markers of immune dysfunction, which then predisposes them to increased infection oftentimes.
And has the field included any types of studies to try and determine if there's any subpopulation of persons with autism who say may be at more risk to develop either clinical conditions such as allergies or autoimmune disorders, or more at risk to develop clinical laboratory findings such as autoantibodies?
I think we think of it that way, where what we're trying to do is almost subphenotype them at a biologic level versus a behavior level. So is there a difference in behavior? Not that we've seen necessarily, in terms of, do they have a higher, worse behavior scores? In the case of the autoantibodies, we do see that, but that isn't really specific to autism. It's more kids who have lower intellectual disability. Even in the neurotypical controls, they're down closer to that cutoff of 70, so they're between the 80 and 90 IQ range.
IQ. Okay.
Yeah, in IQ. In the case of the autoantibodies, it tends to be more to do with the general behavior versus autism specific in terms of intellectual disability and slightly worse behavior on the aberrant behavior checklist. In terms of binning them in immune function, I think one of the most important things to remember, and I've heard people out in the community or clinicians out in the community say, autism is an inflammatory disorder. I think that's the worst thing you could do, is label autism as an inflammatory disorder, because that is not what we see. We see, let's say we're testing for cytokine levels, which is one of the measures of inflammation, we're looking for inflammatory cytokines versus regulatory cytokine levels, and what the disparities are between those two, right? Are they elevated in inflammatory cytokines? We see children that when we stimulate or perturb their immune system in the culture dish, we take their cells out and we stimulate them, kids with a very low response to the stimuli that we give them. We see kids that have really neurotypic responses, meaning they're in the range of the neurotypical age-matched controls that we're looking at. And then we do see kids who have very high, very reactive response to these stimuli. So I think when you talk about phenotyping them, that is what we need to look at. Which population do they fall in? And then we can move from there into what's their clinical picture in terms of behavior and outcome and rate of infection. And I think that's one of the most important things that I try to impart into the community, is that they aren't a one-size-fits-all when we look at them immunologically, and there is no broad category of they're inflammatory, because they're not all inflammatory, and it's just as bad to be non-reactive.
Or hyporeactive.
Hyporeactive, right.
Uh-huh. Now, I understand from my reading, as limited as it may be in the field, that there have been some studies done on human postmortem brain, as well as a number of studies in animal models of autism. Can you give us some insights about what researchers such as yourself have found in these different types of studies relating to immunology, specifically thinking about histological analyses of brain tissue, biochemical analyses of brain tissue, gene expression analyses of brain tissue, to sort of paint a more global picture as things are understood circa 2016?
So, I mean, we've been fortunate that we've had families contributing, that we have a nice biobank that we're building to look at brains of individuals with autism. The challenge of that is always, of course, the postmortem interval, the age, what exposures happen, the cause of death, are always going to color what we see. But, really, the more recent studies, and Dan Geschwind down at UCLA, for example, had a really interesting study where they did gene expression, and they saw in brains of individuals with autism, and seeing upregulation or downregulation of particular what we would call neuronal, sort of neurologic genes, we described it, and a whole different set of genes that were related to immune function. And it was really lovely work in that it demonstrated that while we see changes in genetics, they aren't all in the neural compartment, that we have a whole, tracking along with that, a whole group of genes that are dysregulated in the immune function genes. That was on the heels of the work by...
Even in brain tissue.
This is in brain tissue. right? So this is not peripheral blood like we're looking at. This is actually in brain. A number of studies have shown microglial activation is certainly an active area of interest. I think we don't know, and we need to be careful, and Carlos Pardo definitely talks about this, that we need to be careful that we're thinking of it in a pathologic where it could be trying to be restorative. And that's always the balance, right? Is it trying to regulate itself? Are these genes upregulated because they're trying to fix whatever's going on versus are they causing the pathology? And that's a really important distinction. We're not there yet in understanding that.
Are the animal studies shedding some light on that dimension of the story?
I think they do. The animal models shed light on that story in the context of whatever you've exposed them to, right? But we have very few animal models of autism that are really recapitulating the human, picture. We have, like the Shank3 mice are a good animal model, but are they
Shank3 deficient
mice, right? Are those really representative of what we see in humans? I mean, those are always the questions. Animal models are limited by, the fact that they're mice, not humans. But I think some of the, in some of the maternal immune activation models showing these long-lasting changes in the offspring, brain of the offspring in terms of microglial activation are pointing us in the direction that perhaps, exacerbated microglial activation in autism may be an important player, certainly in changing how the brain develops and then the maintenance of the brain health throughout the lifespan. I think some of the other, there's been less done in biochemical but people are starting to look more at that. We've worked in autoantibodies in individuals with autism and looking at what they recognize in brain. And these autoantibodies are definitely recognizing the GABAergic interneurons. What does that mean? And so we need to identify what they're reacting to before I can answer that fully, and then create the model, right, to understand what they're doing. But I think the fact that they're there in kids that are 3 to 5 years of age, they shouldn't have autoantibodies to anything, right, at the time of their life. And that the fact that they are there points us in a direction that both the immune dysregulation and the potential, ramifications of having these autoantibodies and what they might be doing, presuming that they get into the brain in the first place.
Excuse me. So I think this leads to at least 2 more questions for you.
Great.
From a perspective of clinical research regarding persons either pediatric or adult who have autism, or young children who are at risk at some point to develop autism, what do you see are the most important clinical research questions at this cut in time?
I think if we could functionally assess the immune system in a meaningful way, which I think we can. It requires looking at it probably a little differently than we've looked at it before with, saying, doing a CBC or, just getting a picture of what cells are present in what levels in it, but actually taking cells from an individual, stimulating them in a very specific way to map out the different arms of the immune system and how it responds to those stimuli, I think is one important step in better understanding and in perhaps getting that clinical picture of the phenotype, of the immune phenotype of an individual with autism. I think as we go forward, it'll be really important as the children that we study now age to understand what those changes we see early, how they manifest later on. Do those kids who have this inflammation in this early period end up with autoimmune disease later? Because that means inflammation is an indicator of lack of immune regulation, and lack of immune regulation is one of the pathways to autoimmunity, right? It's much easier to break tolerance to self-proteins if you have high levels of sustained inflammation and lack of immune regulation preventing that. So I think clinically, and I guess there's some research involved there, but clinically tracking these individuals is going to be important. I think it'll be very interesting to look at the aged population in autism and sort of, are there other manifestations that we see, such as Alzheimer's-like disease or neurodegeneration? Does that occur more often or not, in that population? But I think the clinical measures, we can look at immunoglobulin levels just in general, and we showed in a study that lower levels of IgG and IgM happened early in the 2 to 5, but they actually started to normalize as they aged. That was interesting to us because it tells us whatever is going on early they may catch up eventually, but that early period, how is that potentially altering or changing or affecting neurodevelopment that's still occurring at that age? It's not all during the in utero period, right? There's a lot that happens postnatally. So those are some of the key areas of research. Autoantibodies, I think are definitely of interest and may tell us a little bit more about pathologically what might be occurring, because those antigens are getting exposed somehow. They're exposed to those, and if they're neuronal proteins, then somehow there's an exposure there. But I think it's also, and a very important point is, if we know that a child has frank inflammation, they're not going to feel very well, and any behavior interventions we're doing may not be as effective, because you're trying to put that on top of a child that's not going to be as receptive, is not going to feel well. If you can get them healthy, and sort of this is the tack we're taking now, and we have a study ongoing at the Mind looking at exactly this. If we get them sort of normalized in terms of their, feeling better, lower their inflammatory levels, and do the intervention at the same time, would we be more effective in those? So sort of more of a two-prong approach versus this just really hitting them hard with the intervention on top of a child that's just not feeling well. So I think that's probably that's the way things are going now, and it's the synergy between those two versus one or the other.
I see. And in 2016, it's become very clear that autism in children and adults is not just clinically heterogeneous, but is etiologically heterogeneous. In persons that you've studied, in persons who've been investigated in the clinical literature, and in the research literature with animal models, of those persons with autism who have some type of immune dysfunction, whether they're children or adults, or in the animal model systems that are either genetically having immune dysfunction or are treated so as to have immune dysfunction, what are the current thoughts by researchers such as yourself as to the diversity of ways that either hyperactive or hypoactive immune systems, or the presence of autoantibodies in a person with autism, can change the functionality of the nervous system?
Oh, my goodness. Well, I think timing, when this occurs is going to be a key factor in understanding that. My sort of personal thought on this is, one of the things that we know is what happens during gestation, maternal immune activation or maternal immune dysregulation during gestation, whether that's hypercytokine production that's should have been dampened down during pregnancy, actually has a long-lasting effect on how the immune system of the child develops. And so we know that if you perturb the maternal immune system, you actually change the course of immune development in the child. And so not only are you potentially affecting their brain development, but now you're actually also affecting a change in their immune system development, which is lifelong. And so the animal models for maternal immune activation show that you've now have this exacerbated response postnatally in the child, lifelong increased activity in microglial cells. Their recall response to a particular perturbation is higher. So I think we can't really separate what happened in gestation very well from what we see in the postnatal period as far as exposures. I mean, looking at environmental exposures, we're seeing at our Children's Center at UC Davis, we're seeing children with autism, if you take their cells out and you expose them to the same environmental toxicant, and we're using a flame retardant, you get an absolutely dichotomous response in their cytokine profile and production from the ASD, which is very elevated inflammatory looking, versus a typically developing cells from a typically developing age-matched child that is absolutely depressive. So they see things differently, and I think that's in terms of etiology, I think it's going to come down to what are the susceptibility factors that are changing the way they respond to their environment. And in terms of etiology, I think it's going to be a number of factors. I mean, how could it not be? I mean, it's like you're not going to have the same pathway. But I think if we step back globally, changing immune, sort of the immune pathways and how the immune system responds to its environment is going to have downstream effects. The other thing to remember is the signaling molecules that the immune system uses are exactly the same ones neuron uses. I mean, the body didn't reinvent its signaling pathways and cascades. mTOR is the perfect example of that. The mTOR pathway is central to many cell functions, absolutely important, critical for healthy neuron development and critical for healthy immune cell development. If you mess that pathway up, you're going to hit more than one. So getting back to the sort of the more genetic causes, you're going to hit more than one system. And then you have a system that's synergistic, you're really going to mess things up, I think. So I think it's more complicated than saying a cause and outcome. It's a perturbation and how they deal with that perturbation, and then this sort of really complicated interaction that we get downstream of that, which is not helping, I'm sure, trying to parse this out, but at least it tells us we need to sort of step back from this one cause, one outcome, and think more about the integrated system and how we're perturbing that and their responses to their environment.
Yes, and many of the persons who will be listening to you right now are family practice docs, pediatricians, neurologists, psychiatrists. Do you have final words or final thoughts that you'd like to share with them regarding immunological issues in the patients that they have who have autism, whether they're pediatric or adult, in terms of their care?
I think, sort of in a perfect world, we'd be capable, and we are, but I think we need to move it from research into clinical practice. Really good assessment of immune function in individuals, and this is from my perspective, so that we could get a better idea of do they have, we talk about the humoral or the antibody producing part of the branch of the immune system. Are they really effective in that compartment, but their cell-mediated immunity or the cytotoxic T cells that fight viral infection are lacking? To be able to better understand at that level, we can do that, but I think the most clinical labs are not set up to do that. It's something I think we need to develop further to make it available to the community. So, because then a clinician can say, okay, how do we support this branch of the immune system while we damp down this branch? Can we do that? We try to do it in autoimmunity, right? And there are medications out there in the autoimmunity world that we can use to do that, but in terms of an exacerbated immune response. But I think we need to work on supporting the immune response as well. How do we get to a healthier sort of place? And I think for families, this has a couple of ramifications. One is they will, as I said, be better tuned into their interventions. They'll be better capable of taking in, those interventions. But the other thing is you'll have a healthier child. That's what we all want, right? And could you undo damage that's been done? That's a different question. But could you have a healthier support going forward? I think that's going to be key. I think we're working toward that goal to have in a population that wasn't typically looked at this way, to getting the vision to changed a little bit, so that we think about it as this is something that's important in this particular population. It's not just their behavior. There's a whole issue all the health issues, including gastrointestinal issues in autism.
Well, thank you so much, Professor VandeWater, for
Certainly.
providing a beautiful overview of the immune system in pregnancy, theoretical ways in which it can be made rendered dysfunctional or hyperactivated, and ways both in theory this could impact the developing fetus, and the extent to which we have current knowledge that that may actually happen.
Oh, my pleasure.